Hello, everybody, and welcome to part 2 of the pulmonary disorders. We completed the ABG section, and now we're going to talk about the actual pulmonary disorders. But before we get to the pulmonary disorders, let's review some basic anatomy and physiology as it relates to the pulmonary system. We go back to the beginning. We know that there are two parts to the process of breathing, and that's number one, the inhalation. Now, when we think about inhalation or when we perform inhalation, the diaphragm will drop down and the rib cage will kind of move up and out. And it is that process of making the thorax bigger or the intrathoracic space bigger that causes a further decline in the negative intrathoracic pressure. And when there is a decrease over normal negative intrathoracic pressure, in other words, the intrathoracic pressure becomes even more negative, then that will cause air from the atmosphere to be sucked in. And of course, that air will ultimately reach the alveoli, and that is the process of inhalation. But there are really two parts to inhalation. We know that it is not just breathing in air. There has to be the ability of blood to pass through in the capillaries within the lungs to make contact with that alveolar space so that oxygen can diffuse from the alveoli into the blood, and then CO2 can move from the blood into the alveoli and then to be expelled out into the air. So again, the process of inhalation is two parts: the ventilation, the bringing in air, and then Q, the perfusion, that blood movement through the lung tissue or to the alveoli so that gas exchange occurs. And then when we talk about exhalation, exhalation is just simply the elastic respiratory muscles just relaxing. And this is a very low level, low energy process. Now, as we were talking about inhalation and exhalation, you've been breathing, and you haven't even really given much thought to breathing. We breathe when we sleep, when there's no really conscious thought, and we breathe when we're awake. And so, if all things are well with the respiratory system, the lungs are very compliant, meaning they're very elastic and stretchy, and they have the ability to bring in air and get rid of air without any effort or any part of effort on the individuals where the lungs reside. And so, probably the most common thing that is consistent with all pulmonary disorders, irregardless of what type, is that there is increased work of breathing. And so, you, the nurse, have to be able to recognize when your patient is having distress or when they're having increased work of breathing. So here are some signs and symptoms that should indicate to you there is increased work of breathing. Now, when we talk about the term dyspnea, that's really a subjective statement. In other words, the patient will say, I can't breathe. Yes, they may say I'm short of breath, but most of the time our patients will tell us that they can't breathe, and that can mean a very wide range of stress and difficulty. Now, you, the nurse, are then going to have to ask some very specific questions about that shortness of breath or inability to breathe, such as, well, do you get short of breath just sitting there doing nothing? Or do you get short of breath on exertion? And so that can often be abbreviated in the medical records document, the nurse's notes, as dyspnea on exertion, or DOE. And then also, what about the ability to breathe? Can you breathe when you're lying down? Or do you have to sit up? Or do you have orthopnea? In other words, when you do lie down, then it becomes very difficult to breathe and you have to sit up. Now, we've talked about orthopnea before as it related to cardiac issues, specifically left heart failure. But now you have to realize that orthopnea, or the inability to lay down and breathe easily, can occur with individuals with respiratory disorders as well. So again, it's all about the story. The individual tells you a story about they bringing up some things, or bringing up sputum that's different colors and so on and so on. Then you want to link it to a respiratory disorder with orthopnea. But orthopnea is just the general term for the inability to breathe easily when laying down. And then again, there's kind of a caveat to that, which is some people can lay down and do fine breathing for a little while, and then all of a sudden they can't breathe very well. And so that's laying down and they have to sit up. And so that's that differentiation of paroxysmal nocturnal dyspnea where they have to sit up. Now, as nurses, we would ask them, well, in the old days, do you sleep with 2 pillows or 3 pillows? But most patients will tell you these days that they don't go into a bed at all. They just sleep in a recliner. Now, with the statement from your patient that I'm short of breath or I can't breathe very well, you are going to further assess and look at how fast or how slow they're breathing. So we always look at the respiratory rate. And when we talk about normal respiratory rate for adults, it is between 12 breaths and 20 breaths per minute. This is something you have to remember, that the normal respiratory rate is between 12 and 20 breaths per minute. And with that deviation in your patient that's having problems, there may be a slower than normal respiratory rate. And the fancy term for that is hypoventilation or bradypnea. So anytime there is respiratory rate that is less than 12 per minute, then this is going to be defined as hypoventilation. Now there can be several reasons why your patient would have a slow respiratory rate, but one of them relates to the central nervous system. So put a circle around this, because students often think that respiratory problems begin in the pulmonary system, and they can. That's true, they can, but it can also be a result of a central nervous system. And when we think about the lungs, you've got to think that the lungs are simply tools, that the brain is really in control of the respiratory rates and patterns. The brain is the one that defines or decides how fast and how deep or how shallow breathing is going to be. And so therefore, anytime there's a problem within the head, an intracranial problem such as bleeding or a high intracranial pressure, then that can cause an alteration in the respiratory rate. And so again, slow respirations, less than 12 breaths per minute, and then fast respirations or hyperventilation or tachypnea is going to be defined as greater than 20 breaths per minute. Again, several causes for a tachypnea or hyperventilation. It can also be CNS issues depending on what part. But it can also be psychological reasons, such as someone's frightened or they have air hunger, which could be caused by some pulmonary disorders, and so on and so on. You just need to identify what is the respiratory rate of your patient, normal, too fast, or too slow. Then when we talk about the depth of the respiratory effort, because that makes a big difference on how much air can be brought in or how much CO2 can be removed. And depth-related terms would be hypopnea, this is shallow breathing, hyperpnea, that would be increased depth or more air, the tidal volume being brought in, or no breathing at all, and that's apnea. In addition to the respiratory rate and depth, we want to know, is there use of abnormal respiratory muscles? In other words, we talked about the fact that inhalation requires a lot of energy. Yes, we don't recognize that it does, but from a body standpoint, it is more work to inhale. And so we do use chest muscles. We may use those muscles in the upper around the clavicle area and in the neck area, and that is technically normal during inhalation. But remember, exhalation is supposed to be no energy, just a rebound of the elasticity of our chest muscles. And so when you see individuals using these accessory muscles to exhale, then I want you to think that that must mean that there is some kind of distress with the breathing pattern, that is not normal to use these accessory muscles on exhalation. In addition, you might see people or kids and or adults using abnormal or different kind of posturing. When you look at this kiddo, he's kind of leaning forward. He's got his hands supporting his chest. And we call that the tripod position, where you think of a triangle, and that's what this child is performing. Children will often, and some adults too, will have nasal flaring. That might recognize that there is a whole lot of work on inhalation or on exhalation. And so, again, these are signs and symptoms of increased work of breathing. Cough and sputum are often seen in pulmonary diseases, and so you, the nurse, should investigate and look at the cough and sputum. Is it clear? Is it thick and cloudy? What does it look like? We know that individuals can cough for a variety of reasons. It might just be a protective reflex, but it can also be a sign that there's a problem, that there is a reason or irritation in the lungs that's causing this cough. And when hemoptysis or bloody sputum is brought up, that is the term that is hemoptysis, is when there's some red blood cells that have kind of snuck into the alveoli and being brought up with the mucus or secretions. Now we have some descriptors here for what the bloody sputum can look like, and we also have some causes. Read that on your own time. It's pretty self-explanatory, but I want you to think of hemoptysis, the coughing up of blood, as a sign that there is a pulmonary disorder. Sputum could also be foul smelling. It can be cloudy, green, yellow, or brown. And think about an infectious process, the presence of some kind of microbe when your patient's sputum is green, yellow, brown, and cloudy. Now we talk about the definitions of terms, because these are the terms that healthcare providers will use. And so when an individual presents to their healthcare provider with signs and symptoms of increased work of breathing, so those are all the things that we just identified a moment ago, whenever there is signs and symptoms of increased work of breathing, and the patient states, I can't breathe, or I'm short of breath, or I'm having trouble breathing, then that is pretty much defined as respiratory distress. Now, once respiratory distress has been identified by your assessment or observation of what the patient's respiratory rate looks like or depth, and those other signs and symptoms, we will also look at the oxygenation status of the patient, or the CO2 status of the patient, or the pH. And so that's why we did those ABGs in the very beginning, because we will use those as a tool to identify that there is respiratory failure. In other words, if you think of the pulmonary system as in control of the pH, the CO2 level, and the O2 level, when all three of these or two of these are abnormally valued, then your patient has failure of the pulmonary or respiratory system to do its job, and that's when respiratory failure is identified. So respiratory failure can be either a low pH, a low O2, a low pH, or a high CO2, or all three. If all three are abnormal, then it is a complete respiratory failure. So that's what respiratory failure entails. And when there is respiratory failure, then the healthcare provider is going to have to support that respiratory effort through mechanical means, such as a ventilator. Now we've talked about the fact that increased work of breathing will indicate, or should indicate to you, the nurse, that there is some kind of pulmonary disease, and we get now into those diseases. And for our purposes, we are going to divide the pulmonary diseases into two categories: restrictive pulmonary disorders and obstructive categories. Again, we're doing black and white. In real world, there can be a lot of mixture with these. And so for our purposes, so that it's not confusing, we're going to divide them into two categories. And when we have these two categories, then there is a subdivision in the restrictive disorders. And this is a very busy slide of the classification, but it'll make sense as we go through the presentation. Let's talk first about restrictive lung diseases. And the rule that we have is that with restrictive lung diseases, this refers to disease processes that will cause difficulty with inhalation. And when you think of inhalation, that is the bringing in of air, and very specifically the bringing in of oxygen. And so if your patient has a restrictive disorder, then inhalation is going to be a problem, and they will show that there is a problem with inhalation by having a low oxygenation level. Again, that's where that ABGs come in, because the SO2 will be lower or less than 97%, and the PO2 will be low or less than 80 millimeters of mercury. Now, again, when we talked about inhalation, we talked about it as the two parts or stages of inhalation. And that is that the patient will be V, bring in air, and Q, there's perfusion. And so when your patient has a problem with oxygenation status, then we think restrictive disorder, but now we need to really pinpoint, where is the problem? Is it a problem bringing in air with ventilation, V, or is it a problem with perfusion? And we defined the normal amount of ventilation, in other words, the normal amount of air that should be brought in with each breath, as 4 liters. And the normal amount of perfusion is 5 liters per minute. And because we can make this into a ratio of V over Q, so that's the VQ ratio, when you divide that mathematically, it comes to 0.8. Again, you are not going to be asked to do a math formula. You just need to realize that the normal VQ ratio is going to be 0.8. And if it's identified that the patient has some kind of inhalation problem, some kind of restrictive problem that's causing a low O2, then healthcare providers will often do a VQ scan, because there will be a VQ mismatch when there is a restrictive disorder. And again, because it is a ratio, it can either be, or the VQ ratio can either be above, higher than normal, or lower than normal. So again, our marker is 0.8 as normal VQ ratio, and therefore now we're going to further divide our restrictive disorders into restrictive low VQ disorders and restrictive high VQ disorders. So what would be the problem with your patient if they had a low VQ disorder? So a low VQ disorder should be linked to less air coming in. So when you look at this specific example, we say that a patient is not able to bring as much air as normal, and we're just going to use an imaginary volume that they can only bring in 3 liters of air instead of 4. So then when you put that out on a mathematical equation, we see that if they can only bring in 3 liters of air, but they have the normal amount of blood zooming through the lungs at 5 liters, that this is going to give us a 0.6. So the VQ ratio is now going to be less than 0.8, it's 0.6. On the high VQ disorders, these will be patients who have problems with perfusion. There will be less perfusion than normal. So again, if we have a problem that's causing a blockage or decrease in the amount of blood that's supposed to be zooming through the lung and getting access to all those alveoli, instead of 5 liters, it's only 4 liters. When we calculate and plot that out, we see that the normal amount of air is being brought in, so ventilation is normal at 4 liters, perfusion is less at 4 liters, and that gives us a ratio of 1. So that is greater than 0.8. Again, you'll be given the value of the normal VQ ratio, which is 0.8. So here is again that picture representation of what I just talked about. When we talk here, look on the left, when we talk about problems with patients bringing in more air or enough air, there is less air, 3 liters of air per minute versus the 5 liters of blood that is zooming through, then that is going to be a low VQ disorder. And then on the high VQ disorder, there is some problem that's obstructing blood flow, the ability of blood to get to the alveoli for gas exchange. We have 4 liters of air normal, and then less blood, 4 liters of blood. And so that's how we come up with high VQ versus low VQ. That means that we're going to further categorize our restrictive pulmonary disorders or diseases in those that cause a low VQ and those that cause a high VQ. And this is my crude drawing of how we have it put all together. So we look at Our patient presents with signs and symptoms of increased work of breathing. There were several different signs and symptoms, but it doesn't matter. They come in with some kind of sign and symptom of increased work of breathing as identified when the nurse or healthcare provider assesses the patient. Most likely ABGs will be drawn, and once it's determined that your patient has a low O2 state and most likely a problem with inhalation, then another test that can help identify where the restrictive problem is, whether it's a problem bringing in air or a problem with blood getting to the alveoli, then a VQ scan will be performed, and then a VQ mismatch may be identified. So this is where we're going next. We're going to go to all of those restrictive disorders that will cause less air being brought into the lung system, so low VQ disorder. And so here are the many causes that would contribute to poor mechanics of breathing, such as if your patient has a kyphosis, you can see this woman's chest wall does not look like the normal chest wall. This will make it more difficult for the chest to move up and out and to increase that space inside, causing more negative pressure, and therefore therefore air cannot be, as much air cannot be sucked in. Obesity, because if there was a large belly, then your patient's diaphragm can't drop down. And then if there's a neuromuscular disorder, then these patients also have a poor inspiratory effort. In other words, they can't bring in a lot of air because their muscles are weak and they just can't have the effort to bring in as deep a breath as what is needed to bring in enough of 4 liters of air. Foreign bodies can cause an airway restriction, in other words, the inability of air to come in because there's an actual physical obstruction. And inflammation also offers a obstruction or restriction in the ability of the patient to bring in enough air. So when your upper airways are inflamed, then as the patient tries to inhale, they will have what's known as stridor. So that is the sound of air entering the air passages through inflamed air passages. So that's stridor. And we see stridor or hear stridor with individuals who have what's known as croup, laryngotracheobronchitis. Now you can see from the ending of it that it's an inflammatory process. And croup is defined as an inflammation of the larynx, trachea, and bronchi. Again, we're looking at upper airway issues where air or not enough air can be brought in. Now, croup occurs more frequently in infants and children younger than a year. And you can imagine how scary it might be for a child to go to sleep at night and then the parents hear that sound. It kind of does create a panic in a parent, especially a parent not familiar with infectious disease processes. So they will have that stridor. They may have a barking cough. They can have an increased respiratory rate. And again, because it is an infectious process, they may have a fever. What is the treatment? Well, it is often a cool mist. Again, because cool mist will calm those inflammatory or inflamed tissue in the upper airway, and then sometimes steroids is also indicated. It just depends on the severity of the inflammation. Again, we know that often it is caused by a virus, and so antibiotics are not indicated with viral illnesses. Now let's talk about another type or process of restrictive disorder, and that's pleural restriction. Again, we go back to our anatomy and physiology. We have 2 pleural layers. We have the parietal pleural, which is closest to the chest wall, and then we have the visceral pleural, and this is a thin membrane that is over each thing. And then within that pleural layer, there is always a little bit of fluid, because we know as the chest wall moves up and down with inhalation and exhalation, that fluid is there so that friction doesn't form, so that it kind of slides. Those 2 pleural spaces will slide over each other, with the process of breathing. And there is always a little bit of fluid, but there are certain instances, such as whenever there is irritation or inflammation from cancer cells or inflammation from an infectious process, where fluid can collect between the parietal and the visceral pleura. And so whenever there is fluid, you can see that fluid takes up space, and we're in a really limited place because it's inside the chest wall, and so there's not anywhere for the lung to go, so it cannot expand as much, which will cause less air to be brought in. Signs and symptoms that your patient has a pleural effusion: if it's from an infectious or microbe situation, they may have chills and a fever. Most often they will have what is known as pleurisy or pleuritic pain. In other words, when the pleura are inflamed, then it does hurt as the patient inhales and exhales, because that's the whole point. I should say it hurts when they inhale, because that's such an active process. I misspoke, but inhalation is going to be painful. So as they take a deep breath, it's going to hurt because of that inflamed process, and then they cannot breathe as deep as normal, which is why they don't bring in as much air. Again, the amount of fluid is going to depend on how little air is brought in, because the more fluid takes up more space, then there will be less air that goes in. Another type of pleural restriction is a pneumothorax. And the pneumothorax, just like it sounds, pneumo is air, thorax in the chest. So it is the presence of air in the space between the lung and the chest wall. In other words, that pleural space between the parietal and the visceral pleural will have air. And when there is a lot of air within that pleural space, then that will disrupt the normal negative intrathoracic pressure. And without that negative intrathoracic pressure, the lung can collapse. So we have two problems that are created whenever there is air within the pleural space, whenever there's a pneumothorax. We have that lack of intrathoracic negative pressure, which will cause less air to be brought in, if any, and then that intrathoracic pressure that is now positive will cause the collapse of varying amount of lung tissue. So that is the two problems that are created with the pneumothorax. Now, there are three different types of pneumothorax. We first talk about one, that's traumatic pneumothorax, and that's where that's where some kind of penetrating trauma, such as a stab wound or a knife wound, or I took care of a patient that fell against a nail, that essentially punctures the outside of the chest wall, which disrupts the parietal pleura, and then that allows, again, air to enter from the atmosphere into the pleural space, so air will collect. Non-penetrating trauma essentially is a trauma that occurs from within. So if you're a football fan, you think of Tony Romo, back in the day, received a fairly hard hit to the chest. It caused a broken rib, and then that broken rib punctured something on the inside, whether it was whatever of the pleural space, and then caused air to enter in the pleural space. Now, a spontaneous pneumothorax, so this is your picture representation of whichever way. A spontaneous pneumothorax occurs when individuals who are healthy are very tall and thin. If you think of Dirk Nowitzki being 7 feet tall, his lungs are bigger than ours, so they're kind of stretched. And so individuals who are tall and thin, or individuals who are smoker, because their alveoli can be weakened because of the disruption or distortion of the normal anatomy. But either way, you have an alveoli that essentially ruptures or becomes disruptive. And so as air is brought in, then it essentially leaks out. So I think of this in a tire situation. You have an exterior or your tire wall that can be punctured from outside, or you have the inner tube that can be punctured. But regardless of the process, whether it's traumatic or spontaneous, we know that air that collects in there will disrupt the mechanics of breathing, and cause the lung to collapse because of a loss of negative intrathoracic pressure. The third type of pneumothorax is known as a tension pneumothorax, and this can occur in either scenario. In other words, often it is from a traumatic pneumothorax, but it can occur with a spontaneous pneumothorax. It just depends on the volume of air that gets into the intrathoracic cavity, because if there is enough air that collects and that can't ever escape out or around, then all of that air is going to take up a lot of space within that side, wherever the collapsed lung is. And if there is so much air, it will cause a pushing force against the uninjured side as well as the heart. And so this results in a potentially life-threatening situation because of the loss of both lungs, or disruption in both lungs' breathing mechanics, as well as a reduction in the cardiac output. Again, the treatment is going to vary depending on the problem and how acute it is, how bad it is, but the basic treatment for any type of pneumothorax is to restore or reestablish negative intrathoracic pressure. And this is done by inserting a chest tube. So when you look here, you can see that this tube, this is what it looks like. There's various sizes of the tube, but it's a fairly, what I consider to be, if it's in my chest, a fairly large tube that is inserted between the two parietal and visceral pleural layers. And so notice that the tube is inserted between the layers so that air can escape out, and then it's trapped within this water seal in the chest tube drainage system. And then that allows, or doesn't allow, air to return back into the thorax. So if you look at this little O2 molecule that I've represented here in this orange circle, if you watch the flow of air as it enters into the thoracic cavity and into the lung tissue, then as exhalation is done, then that air will go out through the tube, and then it will dissipate outside of the thoracic cavity and not be inhaled back in. So that's how it works. Again, if we look at the air, it goes in and then out, and then stays outside of the lung and does not get trapped within the pleural space. Now we talk about lung tissue restriction. So we're really talking about an infection such as pneumonia in the lower respiratory tract. So again, when we talk about restrictive disorders, it's all about the ability to bring in air. And when there is an acute infection in the lower respiratory tract, then there are problems with the air bringing in air. It is the sixth leading cause of deaths. We see that, even with all of the modern advances in technology and science, that patients can still die from pneumonia. Again, the risk for death or morbidity and mortality from pneumonia does differ for person to person. It does increase when you have somebody who has an underlying lung disorder or any kind of immunocompromise. And there's several other examples of what would offer an increased risk for death from pneumonia. But we really want to focus on the patho of pneumonia itself. And pneumonia is divided into three major categories: community-acquired pneumonia, hospital-acquired or nosocomial pneumonia, and aspiration pneumonia. And the reason why we divide it into three different types is because of the microbe that is responsible for the illness. Because if you think about a microbe in the community, for the most part, it is a less virulent microorganism versus a hospital-acquired organism are much more virulent, and they need lots more treatment or stronger antibiotics to get rid of that pneumonia or that microbe for the benefit of the patient. Aspiration pneumonia can occur in the community or in the hospital. The key point for you is that aspiration pneumonia occurs when someone inhales something that shouldn't be going into the lungs. So again, if I take a sip of my drink, or Diet Coke is what I frequently have in the morning. If I take a sip of that Diet Coke and then I was trying to inhale at the same time, then we know that when it gets into the lungs, I have a good cough mechanism because I'm a healthy individual and I can bring it back up. But individuals who are unhealthy, individuals who are debilitated, such as a stroke individual or someone who doesn't have a mental capacity, who's unconscious, when these individuals inhale something, then they lack the ability to bring it up. And so these individuals can have a compromise or a problem because they cannot bring up these substances that are not supposed to be inhaled in the lungs. Or they have a neurologic problem where they have a very poor cough reflex. So the key here, I've given you some examples in your lecture notes, that aspiration pneumonia is not going to occur in individuals who have an intact mind, who have an intact brainstem, and who have intact reflexes such as gag, cough, reflexes. So again, aspiration pneumonia can occur in the community, it can occur in the hospital, but it shouldn't occur, or it won't occur, because again, we're black and white patho, UTA patho land. It will not occur in someone who is of sound mind. In other words, an individual who has patent or intact cough and gag reflexes. Regardless of what type of pneumonia, whether it's community or aspiration or nosocomial pneumonia, this is the patho that occurs. And I think it will be helpful to you if you kind of draw your own little mini concept map of how it causes a problem. We have something that settles into the alveoli. It can, because pneumonia is a microbe issue, we're going to call it a microorganism that sets into the alveoli, and there are always alveolar macrophages that are just waiting for something that's not supposed to be there to attack. And as these alveolar macrophages attack, they will do a couple of things. They will either activate the systemic inflammatory response, or they'll take care of it at a local level and deal with the problem. But as these macrophages eat whatever is in the alveoli or in the lower respiratory tract that's not supposed to be there, then they will create inflammatory and infectious debris. Now, when we were looking or learned about Module 2, we called that inflammation soup or exudate. But when it's in the lungs, it takes on a different name, and that term is infiltrate. So an infiltrate is the inflammatory infectious debris that accumulates in the alveoli. Now, once this debris or infiltrate accumulates, it will cause or can cause the collapse of the lung because there's no air that can get in there. So again, you have this debris infiltrate that's within the lung, which means there's no air in there. So that's atelectasis. And when you have atelectasis, and you have atelectasis because of an infiltrate, in other words, there is some kind of fluid or pus or blood or water, it doesn't matter what it is, but whenever there is an infiltrate and then there is no air within the alveoli, then the term is consolidation. And again, you can have a few alveoli that have consolidation, or you can have a lot of alveoli that are consolidated. But the bottom line for you as a nurse is, therefore, once there is a lack of air in the alveoli and it has collapsed, it has atelectasis, then there's no gas exchange. And so this is why there is a problem. Now, a lot of people are thinking, or you might be thinking, wait a minute, if there's no gas exchange, why we have this in restrictive? Why is this an O2 problem? Well, because O2 is persnickety. It doesn't diffuse across the membrane very easily or very well when there is gunk in there, when there's an infiltrate in there. And CO2 is not as persnickety. It can kind of work a little bit better, and so that is why it falls in the restricted disorder, and your patient will develop hypoxemia. If it is a microbe, if there is an infectious process, they can have fever, chills, pleural pain, cough, and dyspnea. Again, pleural pain, think back. They will have pain on inhalation, pleurisy, pain on inhalation. If there's fluid in the alveoli, we're going to hear crackles, the sound of fluid in the alveoli. And again, there will be diminished breath sounds because we see or we don't have those alveoli, those groups of alveoli that are not participating in gas exchange, and there's no air flowing through it. Now, here's an important note about atelectasis. Again, atelectasis is when groups of alveoli have collapsed and they're not available for air exchange. And atelectasis can also occur when the lower alveoli don't get air into them. Now, when might that happen? Well, if you think about your patient undergoing some kind of major surgical process, either on their chest, say they have open heart surgery, or in their belly. And I want you to think pain because you've got this recent surgical incision and it hurts for these individuals to breathe in. And so they won't breathe in very deeply because it hurts. And because there is not a lot of air getting down to those lower alveoli, they'll collapse. And collapsed alveoli are a breeding ground for bacteria. So in summary, your pneumonia can cause atelectasis, or atelectasis can cause pneumonia. So either way, when alveoli aren't doing their job, when they're not inflated or they are not getting air into them, then they can cause a problem with collapse. And microbe can get in there and do its thing. So add pneumonia to your concept map of immobility because, again, we have to tell this patient who's hurting like no other, you got to take in a deep breath. Thankfully, the respiratory therapist will help with that, and you got to move. Because the more you move, the deeper these patients will breathe, and we need them to breathe deeply to get all the alveoli involved in the breathing process and air and gas exchange. Moving on to our next topic, and that's pulmonary edema. Now, we've heard of pulmonary edema before. That's the excess of fluid in the alveoli. And we think of it, or we discussed it in the cardiac section under cardiogenic. So that was related to left heart failure. So we had cardiogenic pulmonary edema because of left heart failure. But there is such a thing as non-cardiogenic edema. And we've talked about this in our osmolality, where we had fluid shifts because of an abnormal osmolar state. But I also want you to think about as some other causes of non-cardiogenic pulmonary edema. And one example is when there is injury to the endothelium, such as whenever you inhale smoke, that's going to cause irritation and inflammation. I say inflammation and you say leakage. With that inflammation, there will be an increased capillary permeability. There will be the movement of fluid and plasma proteins from the capillary to the alveoli. Now, we didn't really talk about this before, but whenever there is water in the alveoli, it's not a good thing because it will actually damage the alveolar cells that are producing surfactant. And if you go back to A&P, we know that surfactant is always produced, and that's what keeps the alveoli from collapsing. And so whenever there is a loss of surfactant, the alveoli will collapse because there's no air that can get in there. And again, that's the term atelectasis, where groups of alveoli collapse and are no longer available for gas exchange. Again, so we have water damages the alveolar cells. Surfactant is not produced anymore. There is a loss of surfactant, which will cause the collapse of the alveoli, and that means they are no longer available for gas exchange. What signs and symptoms would you see? Well, you would see dyspnea or shortness of breath, inspiratory crackles, pink frothy sputum, because as that water leaks from the capillary into the alveoli, a little red blood cell will sneak in with the water. And hypoxemia. Now, you might be thinking, well, how the heck am I going to have to determine or differentiate between cardiogenic and non-cardiogenic? Well, it's all about the story. Because in your patient who has a cardiogenic problem, there'll be a cardiogenic scenario, such as left heart failure scenario. But again, in summary, as far as pulmonary edema or atelectasis causes, we know that atelectasis, which is when two or when groups of alveoli collapse and they're no longer available for gas exchange, can occur from a blockage from mucus, as seen in pneumonia, or lack of surfactant as a result of damage to alveolar cells from edema, whether it's cardiogenic or non-cardiogenic. So again, it is often the story that differentiates between the cause, and you're not expected as a nurse to identify the cause. You just have to think in your head, oh, well, this patient just had a heart attack and now they have poor cardiac output and it was in the left ventricle. That's going to be a cardiogenic pulmonary edema versus a scenario where your patient was coughing up gunky, nasty looking mucus. That's going to be a pneumonia scenario. And then if we have a patient who was in a burning building, which you'll smell the smoke on them, then now we think of non-cardiogenic pulmonary edema. All right, lung cancer, another type of restrictive low VQ pulmonary disorder. We know that lung cancer, again, is a problem with proliferation, abnormal cells that take the place of normal working cells. And then this is a picture of some cancerous areas, again, in a patient who is an urban dweller, which could kind of link the fact that, yeah, we all have some nasty looking lung tissue because of the crummy air that we breathe in the Dallas-Fort Worth Metroplex. I think this recording has gone on long enough, and we're going to stop here. If you have any questions, be sure and email your instructor. I hope this has been helpful.